Um, Thank you for this opportunity, EASD 2019 in Barcelona. And glycogen synthase kinase 3 alpha beta inhibition attenuate the progression of diabetic nephropathy beyond the SOX with metformin, Ramipril, and Empagliflozin. And I will talk about a bit of background that bio has a capacity to promote the podocyte differentiation from the parietal epithelial cells in the kidney. Yeah, that's why we want to check this bio drug has a capacity to regenerate the podocytes in diabetic nephropathy. So for that, our hypothesis bio has a specific mechanism of action, would have a therapeutic effect beyond the standard of care in diabetic nephropathy. So as we know that diabetic nephropathy is considered as a leading cause of chronic kidney disease, and it will drive to the end-stage renal disease. And current therapeutic concept do not prevent the progression of CKD in most of the cases. The main thing is there is a experimental approaches between the clinical trials as well as preclinical trials. For example, in chronic kidney disease, our patients are more or less like 55 to 60 years age, and they are suffering with the type 2 diabetes, and we will use the primary endpoint is the declining of GFR, and we will use the standard of care is the metformin, Ramipril, and Empagliflozin to treat the diabetes. And when we will come to the preclinical trials, there is a we will use only STZ treated mice, and or else we will use young obese mice, and our primary endpoint will be either proteinuria and histology, and we will not use any standard of care. So we are trying to mimic the clinical trials in your preclinical trials. And I will come to my methodology that here you can see the age of 6 weeks, I will do the urenephrectomy, and I will give some time like 2 weeks to recover from the surgery. And I will start at the age of 8 weeks, I will start the sodium deficient diet, and it will make the kidney more worse. And when it will come to the 20 weeks age, I will start my treatment. Treatment has a SOX therapy, it has a Empagliflozin, Ramipril, and metformin, as well as I will use my drug is the bio. And when I will come to my results, you can see there is a progression of CKD until the 12th week when I add my drug, and there is a significant decrease from the 12th week to 16th week. So I can say that the GFR is increased after urenephrectomy followed by the progressive decline. Once I add the SOX therapy as well as bio, it's a significantly attenuate the GFR loss during the treatment. And here I can show, I showed the percentage of decline from the 12th week to 16th week. There is a significantly reduction between the SOX therapy as well as SOX plus biotherapy. And albumin creatinine ratio is one of the basic biomarker to check the renal function, and you can see there is a progressive increase of the albumin creatinine ratio throughout the treatment. But when you check from 12th week to 16th week, there is a significant reduction between my positive control to the SOX therapy as well as SOX plus biotherapy. So I can say that it's because of due to the SOX therapy. So finally I can conclude that albuminuria progressively increased along the experiment, and it was significantly attenuated with the SOX therapy due to the metformin as well as empagliflozin, because recent studies are showing that empagliflozin has a capacity to reduce the proteinuria in most of the cases. And I checked the glomerular tuft area also to see my mouse model has kidney is going through the hypertrophy, because basically in diabetic condition there is a lot of cell damage is occur, and there is lot of cells are undergo apoptosis. And as we know that if cells are losing, the neighboring cells are trying to compensate the other cells. By this way they will enlarge their size. So I checked both cortical and juxtamedullary in separately, because the recent studies are showing that when cortical glomes they lost the podocyte, they have a capacity to differentiate from the parietal epithelial cell to the podocytes. When we will come to the juxtamedullary, once we lost the podocyte, they don't have capacity to regenerate the podocytes. That's why I calculated separately between the cortical as well as juxtamedullary, and you can see that in both cases there is a significant difference when you compared with the baseline in both cortical as well as juxtamedullary glomes. And we will come to the podocyte density. This is the one of the most important, because as we know that this bio is directly affecting on the podocyte differentiation. So you can see in juxtamedullary especially, there is a significant difference between my SOX therapy as well as SOX and bio. There is a significant difference between the SOX as well as SOX plus bio. So by these results, I can conclude that SOX plus biotherapy has a significantly increased the podocyte density, especially in the juxtamedullary nephrons. And coming to the fibrosis data, and this is we stained for the series red staining, and separately I quantified the cortical as well as juxtamedullary nephrons. And when you compared with the cortical and juxtamedullary, there is a significant difference between the SOX therapy as well as SOX plus biotherapy in the juxtamedullary nephrons. So I can say that this result is suggesting that the SOX plus bio has a significant reduction of glomerulosclerosis in the juxtamedullary nephrons. And furthermore, this result is strongly suggesting the podocyte density result also. And throughout the experiment, I checked the body weight as well as blood glucose to track my animal health, because body weight will shows the obesity, progression of obesity, as well as blood glucose will suggest the progression of your type 2 diabetes. And coming to the last result, that is I checked the podocyte food process preservation, because we know that bio has a complete action on the podocyte. So I want to see the how much podocyte preservation is occurring in the podocyte. So for that I did the super resolution microscopy to see the preservation of tertiary podocyte food processes. So when you see this, when you compared with the SOX therapy and SOX plus bio, and here I showed the even wild type also, it is exactly looking the SOX plus bio. Not only that, there is a significant difference between the SOX therapy as well as SOX and bio. And finally, I conclude that bio has a renoprotective effect beyond the SOX therapy clinically, and it is a clinically meaningful model of progressive diabetic nephropathy, and it has a capacity to endorse the podocyte differentiation and prevent the glomerulosclerosis, especially in the juxtamedullary nephrons, optimizing the animal model of diabetic nephropathy to mimic the study population and co-medication, and as well as we use the study endpoint. So it is mimicking the clinical trials in the preclinical trials. Thank you for your attention.